Good morning, everyone. I welcome you all for this Niramaya Arthritis and Immunology Foundation virtual rheumatology meet, Rheumatology Clinical Pulse. And today's topic is inflammatory myositis. And today we have two finest speakers of our country, Professor A.N. Malaviya sir and Professor Mishra sir. Professor A.N. Malaviya will speak on dermatomyositis and various subtypes in next 30 minutes, while Professor Mishra will speak on anti-synthetase syndrome and immune-mediated necrotizing myositis after Dr. Malaviya's talk. And after these two talks, we will discuss questions related to this difficult topic. I request all the audience to send their queries for answers from these two experts. Then, brief introduction about Dr. Malaviya. We all know about his credentials, but still, he is one of the senior most rheumatologists of the country, awarded masters from American College of Rheumatology and EPLAR. He is retired HOD, Medicine and Chief of Clinical Immunology and Rheumatology Services, AIMS. Presently, he is heading Department of Rheumatology at Indian Spinal Injury Center, Vasant Kunj, that is Super Specialty Hospital, New Delhi. His major achievements are: he is founder member of Indian Immunology Society, served at various positions as office bearer in IIS, and he discovered low-dose methotrexate for the treatment of systemic autoimmune disease. This pioneer work was published in Lancet 1968. Then he has received various ICMR awards. M.N. Pasi Award, that is the highest award of IRA. API Master Teacher Award, that was in January 2017. National Board of Examinations Scroll of Honor. And he was instrumental in getting clinical immunology and rheumatology recognized by National Board and MCI, and in getting DNB DM courses started in the country. He has trained more than 50 students in rheumatology, many of them at high positions, professor across the country and abroad. He has written various chapters in API textbook of medicine. His particular area is systemic vasculitis, systemic lupus, rheumatoid arthritis. He has published 478 research papers, 331 cited in PubMed till 7th May 2022. He has published more than 50 book chapters. His H index is 42 and I-10 index is 149. He has his papers were cited more than 6,000 times, 6,292 times. His area of interest is RA, spondyloarthropathy, and systemic lupus. Next is Professor Anand Mishra. Currently, he is head Department of Clinical Immunology and Rheumatology at KIMS Bhubaneswar. Previously, he was at SGPGI Lucknow, Professor and Head Department of Clinical Immunology and Rheumatology, and Dean at SGPGI Lucknow. He worked at SGPGI for 3 decades. He started first Clinical Immunology Department in 1989 at SGPGI, and he trained 70 DM clinical immunologists and rheumatologists. All are working at across the country and abroad, and I am one of them. He was awarded EPLAR Masters in 2021, Fellow of the Indian Academy of Medical Sciences 2019, SR Naik Research Award by SGPGI MS 2017, prestigious M.N. Pasi Award by IRA 2013, Samantha Chandrasekhar Award by Odisha Vigyan Academy 2010, FRCP London 2009, ICMR Talent Search Fellow in 1979. He has published 225 papers, total citation more than 8,000, H index 44, and he was past president of Indian Rheumatology Association. And one more interesting thing, Professor A.N. Malaviya was the teacher of Professor R.N. Mishra. And Professor Mishra was teacher of myself. So basically, we are 3 generations today discussing myositis. Now I request Professor A.N. Malaviya sir to start his topic.
Thank you, Banwari. Let me share my slides with you. Here we go. Thank you, Banwari, for inviting me to participate and be a speaker in your organization's meeting. And it is indeed such a pleasure to be with colleague Professor Ramnath Mishra, who long ago was my student at this All India Institute of Medical Sciences in 1980s. I always say that I think I am one of the luckiest rheumatologists, where I have students like Ramraj Singh, Ashok Kumar, Ramnath Mishra, and Rohini Handa, and many others. And why I say so is that quite often during my presentations or discussions, if I am wrong in some presentation or my concepts are not up to the mark or latest, they will always come to me, sir, this is not right, you can change it, which I think only lucky few can have, because I love that my own students still would like me to be perfect and keep helping me off and on if ever I keep on going wrong. And I remember such instances several times where I was corrected for the better. With that background, and with a pleasure to share the platform with Ramnath Mishra and with the chairmanship of a very close friend and colleague Banwari Sharma, I'll start with my talk, the title being Dermatopolymyositis, Various Subtypes. These are my disclosures. Now I'm going to present my way of looking at different types of dermatopolymyositis. And I say so because I know Ramnath Mishra is my colleague speaker. He and many others who are in the field of dermatopolymyositis and way ahead of me in research in this field at present, with the whole group of young rheumatologists studying polydermatomyositis, they may come up with several different types of classification. But I stick to a classification which I am going to give you, which is entirely clinical, easy to understand, and easy to remember. I'm aware that I'm talking to all my rheumatology colleagues, and yet I still find that what I'm going to tell the different types of classes of dermatopolymyositis, this actually is based on Bohan and Peters' 1975 classification, which I still believe is quite useful for clinical approach to patients with polydermatomyositis. And here I go. The first category is that of pure dermatomyositis. Pure means there is nothing to overlap with, no confusion, straightforward skin problem, straightforward proximal muscle weakness, straightforward laboratory abnormalities by way of raised muscle enzymes, and a straightforward EMG findings, and a straightforward biopsy findings, all simply telling that this is a patient with inflammatory muscle disease, which will fit in with classical dermatomyositis. So this is category 1, probably the largest category that we see in our day-to-day clinical work in our routine rheumatology OPD. Then comes the next one, a subtype within dermatopolymyositis. And I will emphasize that such patients, they are otherwise very typical dermatomyositis as I just described. However, there are a few clinical features looking at their face. You can suspect that it might be due to an underlying cancer. And that point I will elaborate in the next few slides. Then is the second category, and that is clinically a myopathic dermatomyositis, commonly called among ourselves CADM, minimal or variable muscle involvement, but primarily presenting with skin problem. And as Professor Mishra is going to discuss in great detail, the main pathology in such patients, the main organ involvement in such patients happens to be lung, which he will be discussing in more detail. So that is the main presentation of CADM patients. Muscle involvement may be trivial, may be very trivial, or may not even be detected unless you do some very advanced studies of muscles like PET scan or something. And then we have the third category, and which is becoming now almost extinct. And this is that of pure muscle disease with absolutely no features in the skin, which otherwise is sine qua non for the diagnosis of dermatomyositis. And that is completely missing in the third category, polymyositis. And because these patients present with muscle disease without any skin problem, majority of them, especially nowadays, will be going straight to neurologists, because neurologists are the one who will look after patients who have weakness in their muscles. So although rheumatologists have started seeing lesser and lesser number of pure polymyositis, and rheumatologists like us have started believing that it may actually not even occur. But if at all it occurs, most of it will be now found in the outpatient department of neurology in bigger hospitals. And why I say so is that what in the past was being confused or considered as polymyositis ultimately turned out to be a deadly type of subclass of polymyositis, where there is massive necrosis, widespread and very rapid necrosis of the muscle fibers, leading to rapidly progressive involvement of the muscles, including that of the respiratory system, and thus making the patient prone to rapid death. And that area will be discussed in great detail by our colleague, Professor Mishra. So I will not be wasting much time on that. And I may be hearing some necroptosis and some other molecules that are possible future targets to control this otherwise deadly subset of dermatomyositis. Then we have the fourth one, and probably this is the commonest in our day-to-day life, because we in our busy rheumatology, general rheumatology, OPD, see a large number of patients with connective tissue diseases, including lupus and systemic sclerosis, Sjogren's syndrome, overlap syndrome, MCTD, sometimes even rheumatoid arthritis. If there are features of proximal muscle involvement and other features of myositis, this is the group which is called overlap myositis. And there are certain characteristic features of it which, time permits, we will be discussing. But something new has happened recently. The category which is given there, you can see right there, inclusion body myositis. It was till recently kept as a separate category. But in the last 3 years, they have found an autoantibody, 2 or 3 autoantibodies in this, one antibody in this subclass of dermatomyositis. This antibody, however, is also seen in patients with some of the lupus patients, some of the systemic sclerosis and Sjogren's syndrome patients, and therefore, it will classically now be included under the category of overlapping myositis. And then we are left with the last category, which our pediatric rheumatology colleagues look at and treat them, that is myositis in childhood or juvenile idiopathic inflammatory myositis. Let us take just one each and in very short summary describe what they are. So pure classical dermatomyositis. In addition, I will also be mentioning this myositis specific antibodies for each one of these presentations. Now, this, of course, all of you know, myositis specific antibodies were first found by MI2 by Reichlen long ago, actually more than 15 years ago. But since then, a large number of myositis specific antibodies has been found in different types of dermatopolymyositis. And the association of these antibodies have brought out the subsets of dermatopolymyositis with great deal of clarity, and it also helps in classifying them, but most importantly, in their treatment, because it determines their prognosis. And so if the antibodies are known, it becomes very important that we give a specific treatment to improve their prognosis. Otherwise, their prognosis probably would not be that good. So in a pure classical dermatomyositis, and one other thing about myositis-specific antibodies, they are peculiar in that if one antibody of the class is present in a patient, it will always be the same antibody, and the patients never develop more than one myositis-specific antibody in that patient. So in one patient, one myositis-specific antibodies, never more than one. What is it? Typical dermatomyositis skin rash, and as you know, it is dermato, which is sine qua non for the diagnosis of dermatopolymyositis. In addition, of course, they are associated primary disease in the skin, and yet they are associated with proximal muscle weakness, and those muscle subtypes, I don't have to go in detail. The proximal muscles, and two of them in the distal also, and one of them in the axial, that is neck. But those are the details which you will be taught by us in the clinic when you are doing the measurement of the muscle weakness. And here are the pathognomonic lesions. Once you see them, there is no other diagnosis than dermatomyositis. And if there are papules present on the dorsal surface of MCPs and PIPs, they're called papules of Gauthern's. But if the papules have healed, or if the papules are present on the external, on the surface of the joints, other than the knuckles and the PIP joints, they are also called Gauthern's sign. For example, here is the healed Gauthern papules, and if the similar lesion is present on the elbow joint or on the surface of the knee joint, they will be called Gauthern's sign. And that's the difference between Gauthern papule and Gauthern's sign. Here is another sign, pathognomonic of dermatomyositis, and this is called heliotrope rash. Heliotrope is a beautiful, highly fragrant flower, which I used to grow when I was in All India Institute in my own house. And this heliotrope rash, here you can see the healing heliotrope rash. It is present on the eyelids. This is the color. It's pathognomonic. If this is present, no other disease except dermatomyositis is the diagnosis. And now here you see, this is the Gauthern papules here, while this is Gauthern's sign on the surface of the joints other than MCP and PIPs. That is sign, these are papules. This is typical shawl sign or the V-neck sign of dermatomyositis. These are pathognomonic signs. If they are present, no other diagnosis is possible. Now, Dr. Kapoor's, my colleague, very dear colleague of mine, Dr. Sanjeev Kapoor's patient, and he has given me permission to show it to you. Here is a typical dermatomyositis, heliotrope lesions. You can see the V sign here. The patient is on treatment, so the severity of the lesion is much less. And she, in addition, of course, has typical proximal muscle weakness of subacute onset. And you can see she is still sitting on a wheelchair. Now, dermatomyositis that I just described, I mentioned historically the first one discovered by Reichling in USA long ago. But since then, we have now 4 myositis specific MSAs associated with classical dermatomyositis clinical picture. Commonest, MI2, it's a benign disease, responds beautifully to methotrexate. And in the beginning, you may give it along with glucocorticoids. Glucocorticoids may be tapered, and methotrexate becomes the drug of long duration, and patients do very well. No association with any bad complications like cancer or interstitial lung disease. Then we have the second one, anti-SAE antibodies, and then we have on the other side anti-TIF1 gamma and anti-NXP2 antibodies. Now, the difference between these two and the skin between these two is the severity of the skin lesion. In these two, the skin lesions are mild to moderate. And the person is usually a younger person. On the other side, on this side, the patient is an elderly person. And the skin lesions are so severe, as if they are dripping with these lesions. When you see the face of such persons, you know this elderly person with dripping rash, typical that I showed you in the last slide. You will say that most likely this patient may have either of these two antibodies, and we have to be then very careful about that. And I'm going to talk about that. So let us see that. Antibodies, as I said, these are exclusively seen in typical dermatomyositis patients. Severe on this side, milder lesions on this side, slightly more in anti-SAE, less severe rash in MI2, severe rashes in both of these when seen in adults. And here is a typical classical anti-MI2 antibody patient. She has mild, typical sun-sensitive, photosensitive rash with a little bit of a heliotrope that you can see. And it is crossing the nasolabial fold. You can see the rash here also. And it is going down up to this. And she is a young-looking person. Classical MI2 antibody. This will be responsive to steroids and methotrexate. And she will not develop any cancer or any lung disease or any such severe manifestations. On the other hand, suddenly you now see a dripping type of severe rash, which is crossing the nasolabial fold. It is photosensitive. She has heliotropes as well. And you can see that she is an elderly person. And in them, it is most likely that it will be associated with TIF1 gamma or anti-NXP2 antibody, or they can also be SAE antibody. And if these antibodies are present, especially first two, it becomes mandatory. Even if they have no sign of cancer, it becomes mandatory to screen them with a PET scan to find out in situ carcinoma somewhere, a small little area in the hilum of the lungs, which may be very active metabolically. And biopsy of that has to be done because it is a medical legal reason. If the patient develops cancer 2 years down the line, you might be called by the court. Why didn't you diagnose that in situ cancer when you saw this patient for the first time? So remember, if such a severe dermatomyositis, and by chance if they have anti-TIF1 gamma or anti-NXP2 antibody, and of course, rarely, if SAE is also present, I think we are obliged to send the patient for PET scan to find out, even if a small lesion somewhere in the body is hiding as a cancer. And here I would like to mention one other thing. When we say cancer-associated dermatomyositis, what do we mean by cancer association? Let me give the definition. Definition is 3 years prior to the onset of dermatomyositis, going down up to 3 years from the onset, after the onset of dermatomyositis. These 6 years are within the range when, if the patient develops cancer, it is called cancer associated with dermatomyositis. And that is the definition you have to use. If the cancer was present 9 years ago and now patient has dermatopolymyositis, it is unrelated. Similarly, if the patient is in complete remission and develops a cancer 10 years later, that is also not associated with dermatopolymyositis. Then we come to CADM. Dr. Mishra is going to discuss it in great detail, so I will not really be bothering much about it, except to say that skin lesions here are very different, almost non-existent, but they exist in a certain subcategory, which I will show you here. There are two main categories: anti-synthetase syndrome, which is further divided into anti-jovan and anti-non-jovan, which Mishra will go in detail. The second category is that of MDF5 antibody subcategory of CADM. Now, anti-synthetase syndrome is characteristically associated with typical skin changes in the hands. And they are so typical that even if other features are not present, but if these features are present, mechanics hand they are called, they are so typical that if you see such a patient, you are obliged to do a CT scan in such patients and let the patient be seen by an experienced rheumatologist who has seen many such cases, because they will turn out to be anti-synthetase, which otherwise will progress rapidly and involve lung, and then at a late stage it may not be treatable. But I leave all those details to Mishra, except for you to show, for me to show you the skin lesions, because recently such a thing happened. A patient, only a photograph was sent by one of my colleague doctors, that here is a patient, she is going from pillar to post, and at one look of the hands of her, it was quite obvious she has mechanic's hand. And then I called her and she was typical anti-jovan, and although antibodies were negative, and what she had, I will be telling you in a moment. So here we are. This is typical of mechanic's hand. There are cuts and this type of lesions on the tip of finger, but much more important is to look at the lateral side of the border of the index finger. It is rough, and this kind of skin excoriations are seen there, and when you touch it, it is indurated. It is so typical that if you come across this, this is nothing but a patient with mechanic's hand, and we have to then entertain the possibility of Jovan anti-synthetase syndrome of mechanic's hand. And if then you go and look after this patient, you have to first go for HRCT, because they are prone to this kind of disease, which Mishra will be discussing in detail. MDF5 is also characterized by such a severe type of vasculitis, which leads to extensive ulceration in the skin. So here the skin manifestations are rather different than classical dermatomyositis. Because of the vasculitic involvement, they start showing ulcer formation. Of course, this is an extreme which was published in Rheumatology, Oxford, and I'm just showing you the extreme form of this. But Kapoor showed me again this patient, and this is again typical of MDF5. Look at these lesions, vasculitic lesions all over on the back, on the front. Typical MDF5 with a rapidly progressive difficulty in breathing, and such patient will be susceptible to early death unless you detect very early and treat them aggressively, although the treatment is not satisfactory till today. Look at these ulcers, and they look very different than classical dermatomyositis. Here they may resemble a bit of Gotham's papules, but you can see the ulcerations all over. So it is MDA5, classical. More of that. Mechanics hand, MDA5. Pure polymyositis, this is what I was discussing, which will be seen mostly in the outpatient of neurology rather than in neurology rather than dermatology. Subacute, high CPK levels, absence of rash, absence of overlap with CTD and other features. But what Mishra is going to talk, and I must mention this, this is a rapidly progressive necrosis of the muscle fibers. These patients are rapidly progressing towards death unless they are treated early and detected early, and the death occurs due to severe involvement of the muscles of respiration. Polymyositis, like picture, and what we used to call polymyositis in the past, 90% of them are now turning out to be necrotizing autoimmune myositis of this category, which again, I leave to Mishra to discuss it. I will, of course, like to hear about necroptosis, which seems to be the molecule as the basis of the pathology of this. And now scientists are going to target this molecule to find a cure for this disease. In this type of rapidly progressive necrosis of the muscles with bad prognosis, the antibodies seen are anti-hydroxy-methyl glutaryl coenzyme A reductase. A mouthful. So anti-HMG-CR. This is an enzyme which helps in synthesis of cholesterol. And as you know, statins suppress this enzyme, and thus statins help in reducing bad cholesterol in the circulation. Now, many people in the beginning thought that those who have anti-HMG-CR antibodies is due to their treatment with statins. But it turns out that a large number of these patients who are suffering from this kind of severe, rapidly progressive muscle necrosis, they actually have never taken statin. And yet they have antibody, which is anti-HMG-CR. So remember, this category, it is not necessary that you will have a history of statin. And if you read the latest literature, in fact, millions of people are on statin at present in the whole of the world. Very few of them actually develop this kind of myositis. So statins are one of the safest drugs, and one should not get scared because some of them have been reported to have this type of necrotizing autoimmune myositis. In addition, this category also, the NAM category, patients may also show another type of antibody, and that is anti-SRP, and the third category, which is anti-SMN. So anti-HMG-CR, anti-SRP, and anti-SMN, any three of them, if present, you can suspect immediately this patient is a seriously ill patient and is going through massive necrosis of muscles with bad prognosis. However, remember, right from the beginning, day one that you see a patient and your reports come that no antibodies are found in the serum, in the blood of that patient. That is called antibody null category. In null category where there is no MSA, this is another subtype where NAM can occur. In addition, now we also know that those who have no autoantibodies in their blood, and by the way, the number is 60%. If you get 100 patients to study with dermatopolymyositis, 60% will belong to null. They will not have any antibody in their circulation. So those who are null without antibody, they are both prone on one side to cancer, as well as on the other side, necrotizing autoimmune, rapidly progressive necrotizing myositis. Therefore, in such any of the four presentation, immediate immunohistopathological diagnosis because they have severe disease and they are unresponsive with bad prognosis. And this I just mentioned, statins and myositis, rarest of rare, nothing to worry really, but can occur. Overlap myositis, I have already discussed that many of our patients in the routine general OPD of rheumatology, we see many patients have muscle weakness, but nothing to bother you, treat the underlying disease, and many of them will be all right, except a few points. Those who have NT-CoO, they are prone to interstitial lung disease. Those who have NT-PMSCL, they are also prone to ILD. Those who have U1RNP, they have more presentation with scleroderma-like overlap syndrome. And those who are anti-SSA-Rho, if the Rho is anti-Rho 52, this is very new, and there are 2 recent papers. If the antibody is anti-Rho 52, they are also very prone to interstitial lung disease. So that's the importance of Rho 52 nowadays and anti-CoO nowadays. So more and more persons, we are now coming to know, more and more antibodies, we are now coming to know they are prone to interstitial lung disease. So we will have to become an expert in interstitial lung disease, but that is for another day for discussion. Inclusion body myositis, the rarest of rare presentation. I won't go in detail, except to say this is one of the overlap syndromes where antibody has been found against cytosolic 5' nucleotidase 1A. Childhood is something very special. They are commonly present with NXP2, less commonly with TIF1 gamma. And you just remember, I were told, and I'm sure you know, NXP2 and TIF1 gamma suddenly raise alarm. Oh, they are cancer related. No, 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 not in childhood. That's the beauty. If NXP2 or TIF1 gamma is present and the onset is in childhood, it is not associated with cancer. How beautiful. But if these antibodies and the patient presents for the first time in adulthood, that is associated with cancer. But then what is the significance of these 2 antibodies in childhood? They are associated with massive calcinosis cutis. They are called calcium tumors. They are so big and in soft tissue that they may even interfere with normal functioning of the person. And I have some patients from All India Institute days still in the follow-up. And I remember they used to have calcium tumors in their subcutaneous tissue, which our friends in surgery had enucleated so that they can at least move normally. So that is the importance, massive calcinosis cutis in NXP2 or less commonly in TIF1 gamma antibodies when seen in childhood dermatopolymyositis. Here it is, NXP2 and TIF gamma in a child. And now I finish with antibodies associated with cancer, TIF gamma, NXP2, SAE, anti-HMG coenzyme A related, but statin related, questionable. Anti-SRP, yes, and anti-null. Antibodies associated with ILD, of course, Jo1, non-Jo1, MDA, CoO, and PMSCL, and now we know anti-Rho 52. Name 3 antibodies associated with NAM, anti-SRP, anti-HMG coenzyme A reductase, and anti-SMN. Name the antibodies that may be seen with CADM, Jo1, non-Jo1, anti-MDF5, and SAE. These are suggested reading and references. With the discovery of myositis-specific antibodies and myositis-associated antibodies, I will strongly recommend that we stop using term idiopathic because they are all autoimmune, and that's why we should call them AIM. Thank you for your patience. And I stop.
Thank you, sir, for excellent talk on dermatopolymyositis. We will take questions after Dr. Mishra's lecture. Now I request Professor Ramnath Mishra sir to speak on anti-synthetase syndrome and immune-mediated necrotizing myositis. Dr. Mishra sir will speak on this topic for next 30 minutes. Professor Mishra.
Thank you, Banwari. Again, thank you for giving me this opportunity to share the platform with Professor Malaviya, my teacher. And well, I'm most grateful for him because what I am here today is largely his influence and subsequently tiny minute influence. Professor Malaviya has given a detailed description, importance of myositis-specific autoantibodies and myositis-associated antibodies in defining subtypes of idiopathic inflammatory myositis. But I would be focusing on two of these, immune-mediated necrotizing myopathy and anti-synthetase syndrome. These are relatively, the immune-mediated necrotizing myopathy is a relatively new concept.
Sir,
So,
can you share your slides?
okay. Is it okay?
Yes, sir. Yes, sir.
Well, what I was suggesting, or what I was saying, that these are relatively, this group has been seen in the last 15 or 17 years. And though we had individually seen cases that we have lost, but to identify them as a subset is relatively new, I think, because myositis-specific autoantibodies, the one that Professor Malaviya said, the entire spectrum, including the anti-tRNA synthetase, they were described earlier. SRP was described earlier, but the AMG-CoA reductase, that is relatively new. And what is a characteristic, clinical characteristic, is a fulminant course where it has present acute or subacute onset, but the hallmark is rapidly progressive muscle weakness and CPK in the range of thousands. The median range in 16 cases that were first described as 7,000. Rarely, we also encountered that. The involvement of skin, lung, or kidney is rare. So one would encounter like a polymyositis setting, not like a dermatomyositis setting. And there is myopathic pattern in EMG. And we believe that unless there is aggressive immunotherapy, patients have either devastating functional outcome or mortality. Whatever case I remembered with antibody to SRP, they ultimately succumbed despite, and the third case had rhabdomyolysis, serum creatinine rise, which was because we thought it was due to statin because of intermittent use of statin. Not many centers are lucky to have these myositis-specific autoantibodies. SRP can be detected by ELISA and line plot, and HMG-CoA reductase also can be detected by ELISA and line plot. And if one is aggressive enough to do a muscle biopsy, one doesn't find the lymphocytic infiltrate, but find scattered necrosis of the muscle fiber. This is very characteristic. And I would discuss the three major things. One is anti-HMG-CoA reductase group, the SRP group, and the antibody negative. Seronegative immune-mediated necrotizing myopathy is still a poorly described entity. The autoantibody status in this disease has considerable correlation with clinical phenotype, prognosis, and the choice of the immunosuppressive treatment. Professor Malaviya referred to the antibody to the survival motor neuron signal, which have been also a part of necrotizing, immune-mediated necrotizing myositis. But the number of cases that are reported are so few, and unless you have an immunoprecipitation method to detect, most cases it is undetected. Fortunately, the line plot, the extended line plot used by Euroimmune, can detect the range of autoantibodies, including SRP. The latest one, I have to check whether HMG-CoA reductase can be detected or not. So I would restrict myself to the SRP group, the HMG-CoA reductase group, and the antibody negative group. For the antibody to SRP antibody, we have high creatinine kinase. Muscle weakness can be variable. For the anti-HMG-CoA reductase group, proximal muscle weakness is a definite entity. And of course, if it is antibody negative and rapidly progressive weakness, we need a muscle biopsy and to find necrosis, macrophagocytosis, regeneration, the lymphocyte infiltrate apopsy, and some describe increased HLA class 1 expression over the sacrolemma and the terminal complement complex, which is otherwise called the MAC here. As Professor Malaviya suggested, clearly the pathologic signal is that of an immune-mediated damage. Well, basically, this is a cycle that is induced by the endoplasmic reticulum, the expression of the SRP and the HMG-CoA reductase antigen. There could be some trigger that initiates a kind of cellular damage to the muscle group, which amplifies it in a circuitous way. One can demonstrate the membrane attack complex, the C1q, and the class 1 HLA molecule. The antibody to SRP myopathy is clearly one of the most disabling autoimmune myopathies. When I would consider what Professor Malaviya says, antibody to MDA5. Antibody to MDA5 is usually a retrospective diagnosis. You see in front of your eyes an acute progressive respiratory failure and most patients would probably succumb in intensive care unit. I mean, they would probably not come to the rheumatologist or neurologist. They would present with respiratory failure. SRP myopathy would present to either a neurologist, internist, or rheumatologist with severe muscle weakness. The CRP could be 50 times more. They may have cardiac involvement, and interstitial lung disease is minimal. Women are more affected than men, and interestingly, dysphagia is present in half of them. And muscle damage is more intense as compared to HMG-CoA reductase, and therefore the outcome of these patients is poor. One of my patients is still in a wheelchair. He didn't recover. Anti-HMG-CoA reductase is said to be recovery is within 2 years. Participants with anti-SRP were significantly more likely to have muscle atrophy or wasting or fat replacement compared to HMG-CoA reductase. Well, I would consider both a bad disease. Whereas the other group defined by HMG-CoA reductase, those which are steroid statin naive, they tend to be younger, have higher CK level, and more likely Asian. Whereas those which are associated with statin usually belong to the elderly group, sometimes even beyond 80 years old. And younger patients are more responsive to treatment. Anti-HMG-CoA reductase, immune-mediated necrotizing myopathy, it generally affects male and women roughly equally. The larger cohort from North America have suggested that 1/3 doesn't have statin exposure. Professor Malaviya alluded to this point. But once there is this condition, statin cannot be introduced. And again, ILD is seen very rarely. This entity, like those which are serologically negative for either SRP or HRCGA, these are the ones which are likely to turn into malignancy. One can also draw an analogy with the myositis specific autoantibodies, which Professor Malaviya said the broad spectrum. If one is seronegative for either MSA or even for MAA, then they are likely to have a malignant risk. And here, in face of a progressive muscle weakness, one needs to recommend for cancer screening. One of our patients had a metastasis in the liver and progressive acute fulminant muscle weakness. The good ones are elderly, female sex, and initial use of IV methylprednisolone. The bad ones are young age, black race, delay in treatment. The goals of the treatment, obviously to improve the muscle strength, that is the MMT, normalizing the creatine kinase, and minimizing the medication side effect. All patients would suspected necrotizing autoimmune myositis should be given a combination of steroid and another immunosuppressive drug, such as azathioprine or methotrexate. In other dermatomyositis or in other polymyositis, generally we start with steroid alone and wait an approach of second line, third line drug. Here, we don't have the time. So the recommendation, at least from the European group, has come to use steroid with anything, azathioprine, cyclosporin, mycophenolate, and if you find SRP, introduce rituximab, or if you find HMG co-reductase, use IVIG. But other drugs have to be used concurrently. Plasmapheresis has been of limited success. So if it is rituximab is to give in for antibody to SRP, and IVIG for HMG co-reductase, and steroid started with 1 milligram, and other immunosuppressant drug to be used concurrently with corticosteroid. And of course, intermittent IVIG, perhaps 1 month, 2 months, 3 months, 4 months, can be helpful in the HMG co-reductase group. So this is the European group recommendation. You start concurrently with steroid and methotrexate. If there is no response by a month, start rituximab. One can, even if it is antibody to SRP, you don't wait. Steroid and rituximab can be given. And if not adequate response, you can, sometimes typing these antibodies is an issue. So one has to go by your clinical parameters of response. Methotrexate, obviously, if there is remission or response, has to continue for 2 years and then slowly taper off, and rituximab to be given for 2 years. If IG is given, one give it for 3 to 6 months. I think Professor Malaviya did a fair job in describing autoantibodies to tRNA synthetase, which have a distinct clinical phenotype. They are moderate muscle weak. They have a variety of extramuscular manifestations like the skin rash, the mechanic hand, fever, myositis, ILD. In fact, some of these, particularly the rash that Professor Malaviya described, they are so typical of this disease, one need not try to assay for the autoantibodies. However, there are cases where you get the typical cutaneous feature, but the autoantibody that comes out is either antibody to Rho or RNP. Interestingly, if one does myositis-specific autoantibodies in 100 cases of, say, dermatomyositis, you will get MSA in about 20% cases. A vast majority of them would have MAA. There is a diagnostic criteria. The recent one requires the presence of the antibody. So that is a mandatory criteria. Plus, you have to measure, which is ILD and polymyositis or dermatomyositis, or either one of these to be considered with 2 minor, arthritis, Raynaud's, and mechanic hand. So there is a strong HLA association in the European American patients. It's not studied here. And there are studies to show that there are CD4 T cell reactive to the amino acid tRNA synthetase. So you not only get the antibody response, you get the cellular response. These are the list of antibody to tRNA synthetase. In the initial evaluation at SGPGI, Jovan could be seen in 20%, and these are extreme rarity. PL7, PL12 is 1% to 2%. The conventional Euroimmune or the extended Euroimmune strip that we now have, it can measure assay for OJ and DJ, but I'm not sure about the KS, WA, YRS. So it's very expensive to test also. Each of them, Jo1, PL7 and PL12. PL7, PL12 is rarity, but Jo1 is seen in 25% of cases where you suspect anti-synthetase and you get arthritis, Raynaud's and mechanic sand. And the other typical feature of anti-synthetase is ILD. It's a very consistent occurrence in presence of the antibodies that almost all of them would have some form of ILD, mostly of the NSAIP pattern. The muscle involvement is generally described to be moderate and not as aggressive, fulminant, and severe as defined by the necrotizing group. Creatine kinase levels are usually elevated, but not in the range of 7,000. It is elevated, maybe 1,000, 1,500. And you can get a myopathic pattern. And if associated with Rho52, you have more severe lung, muscle, and joint. The thing is, this group of disease, they are moderately response to immunosuppression. They are not like the MI2 disease. They are not eminently responsive to the joint involvement is like rheumatoid arthritis only. And sometimes while examining for patients for arthritis, you see the mechanic sand, and that raises a suspicion that it could be anti-synthetase syndrome. Mechanics hand is only seen in 15 to 20%, and classic cutaneous manifestations are seen in 50 to 75. Raynaud's is a very predictable thing. Here, if you do muscle biopsy, you see perifascicular pathology, and biopsies. Rheumatologists don't usually do it because the clinical dermatological manifestations are so typical that invasive investigation can be avoided. In fact, I've read a paper several years ago with the extended spectrum of MSA that would we ever require a biopsy. So you have these clinical subtypes of anti-synthetase. Jo1 have myopathy, dermatomyositis. Dermatomyositis, we have anti-JPL7 and anti-MDF5. ILD goes with Jo1, also with PL12, KSOJ, MDF5. This MDF5 is the worst category. You cannot save these patients. They kind of rapidly progress into respiratory failure. Whereas the milder ones, arthritis, Raynaud's fever, muscle weakness, ILD, these are typically seen with Jo1. There are incomplete variant, much like we have the incomplete variant of Basets. One can have one or two features, yet they are associated with antibodies. So the treatment guideline is not based upon the randomized control trial. That is the sad thing here. Neither this nor the previous group I described, they have not been based on randomized clinical trial, controlled trial. So you start off with corticosteroid, wait up for a month or 6 weeks, then add second line drug. One of the drugs they do as well as the other, And then in case of persistent inflammation, one goes to cyclophosphamide and tacrolimus. And of course, in refractory case, rituximab is the standard of care, I think. Though the randomized clinical trial had 50% confidence. So this is the drug doses. To this audience, I think it's very common, but these are difficult, you know. Once you add a immunosuppressive drug like cyclophosphamide, mycophenolate, there is always a chance of secondary infection. Many of our patients, I feel sorry that after 6 months or during 1 year, when the clinical disease is in remission, they succumb to secondary infection, mostly on pneumonia because of ILD problem. These two papers are the effectiveness of rituximab in anti-synthetase syndrome. And the four prognostic factors are old age, African American ethnicity, male gender, UIP picture on HRCT, symptomatic ILD, and most important, after 6 weeks of treatment, if they do not improve, that is a very important predictor of poor response. There are studies on survival, mostly from the University of Pittsburgh, which say that 90% of them with Jo-1 survive for 5 years, and non-Jo-1 75%. We do not have a survival study in India, but I believe that the 10-year survival is close to 50 to 70%. So half of them succumb by 10 years. And I think mostly they have pneumonia. So clearly immune-mediated necrotizing myopathy is severe, aggressive course in terms of muscle necrosis. One has to be very severe with treatment approach. And despite that, the outcome is not good. Whereas anti-synthetase syndrome, one can approach their clinical characteristics are very typical. One can make an anti-synthetase syndrome based on the skin rash, the combination of ILD, fever, and arthritis. And they are moderately response to immunosuppressant drug, but they have much better outcome than the immune-mediated drug. Thank you, Banwari.
Thank you, sir. Thank you for excellent talk. And after these two fantastic lectures, now we will have questions. We have a lot of questions. I start one by one. First question goes to Dr. Malaviya, sir. Sir, we have one patient who is 36 years old man, has heliotrope rash and V sign, no muscle weakness, LDH CPK mildly raised, EMG is normal, ANA is 3 plus speckled pattern, all myositis is specific and myositis associated antibodies are negative. Can we still call this patient as clinically amyopathic dermatomyositis? And what should be treatment protocol? This is from Dr. Vikas Sharma, IGMC, Shimla.
If the patient has the skin lesions that are described, as you remember in my presentation, I have named these lesions as pathognomonic, which means if these skin lesions are present, the diagnosis is dermatomyositis. Now, the issue is many of them may not show that much involvement of the muscles, but if you go for very sensitive studies to see muscle involvement by way of a PET scan, you may find a small groups here and there that will show high uptake, which will indicate that there is high metabolism and involvement with inflammation. Regarding the treatment, it is very well known that the skin lesions of dermatomyositis respond only to real drugs that we use for in this disease, which in short means that yes, the patient will need treatment, whether you start with methotrexate or with azathioprine. But one point to be remembered that the patient is so-called null, seronegative. And that's why, again, I come back that there could be the problem of malignancy hidden somewhere. And therefore, you will have to do that, which will help you in two ways. Number one, it will show you a small involvement of the muscles at different places, which will further confirm your diagnosis. In addition, it will also, at least to your satisfaction, rule out any underlying cancer. And with these two, you will have to treat the patient. And the British Society of Rheumatology has come up just 3 weeks ago, the revised treatment, which Dr. Mishra presented. That's the standard treatment. And I have already made the slides for teaching. I may be able to put it on my Yahoo Google group very soon. And it says that, of course, as Mishra has mentioned, glucocorticoid must be given in every patient where you have already made the diagnosis and you are going to start treatment. So in your case, now I have given the summary. You have a case with null who has pathognomonic lesions. The diagnosis is dermatomyositis. You will go through all the other tests, especially ask for esophageal involvement, which puts the patient in a severe category if it is involved, plus Raynaud's phenomena, that also makes it a severe category, plus, of course, the breathing problem and all that. And you will then do a PET scan to find out the extent of muscle involvement, which may not be clinically apparent. And you will exclude cancer. And then you will put the patient on a quickly reducing dose of glucocorticoids in the beginning, and you follow it up with either azathioprine or methotrexate. Now that we know that methotrexate in the classification that Euler has given does not fall in the category of immunosuppressive, but in immunomodulator, as against azathioprine, which is immunosuppressive and not an immunomodulator, I will prefer methotrexate as the basic underlying treatment, which will go on for several years, and tapering dose of glucocorticoid. Thank you.
Sir, can we use MRI instead of PET-CT in this patient because he is seronegative and he has moderate risk for malignancy?
I guess you can. I'm no expert, but maybe Mishra can help. I guess you can, but I just want to be sure that if the patient is null, possibility of malignancy should be ruled out. And here I bring up another point. Although we say TIF, gamma, and NXP2 and SAN, they are associated with malignancy. But let me state it. All the patients with dermatopolymyositis are prone to malignancy, and the incidence is higher than normal population. Yes. Every time. And yes, this must be kept in mind.
Absolutely, sir. The only issue is like patients who are positive for anti-TIF1 and anti-NXP2, we should go for PET scan straight away. Absolutely correct. But regarding other groups who are negative of these autoantibodies, should we go with PET-CT straight away? Dr. Mishra?
I am just quoting the literature. I have no experience. Mishra can add to it.
Sir. No, I would agree with Banwari. Those which are well-known, strong associated markers, those are the ones you need to go in straight for PET-CT. The others, you do a conventional screen. There is no recommendation that one has to do, but I agree overall with Professor Malaviya that both polymyositis and dermatomyositis have a risk of malignancy association in general. And if they are antibody negative, probably the risk is higher.
Yeah. Next question to Dr. Mishra, sir. Sir, I have a patient of MDA5 myositis and has diffuse alveolar damage. We are treating her with combination of cyclophosphamide and tacrolimus. Cyclophosphamide every fortnightly, 4 doses till now, and tacrolimus to keep levels at 8 to 10. For how much time we should continue and what should be the maintenance plan? Patient is doing well till now. Again, this is from Dr. Vikas Sharma, IGMC Shimla.
The cyclophosphamide and tacrolimus, they have to be given for 2 more doses. So 6 months treatment with that, and then they can continue with tacrolimus. Cyclophosphamide cannot be given beyond that time, and one has to step down the treatment to an oral immunosuppressive, or you can, I would prefer azathioprine. But I must congratulate them that with MDA5 disease, they have been successful. For
surviving patients.
Yeah, they are just lucky. The ones that I have seen, I've seen them in the casualty and then in the ICU, then retrospectively find out that they are MDA5.
But as Dr. Malaviya has said that if we diagnose these patients early and treat aggressively, then some of the patient can be saved.
Yes, definitely. Definitely.
Next question to Dr. Malaviya, sir. Is myositis specific autoantibodies always mutually exclusive?
Yes.
Dr. Soumya.
Yes.
Okay, sir. So sometimes we do see reports of 2 autoantibodies positivity, one high titer and another one is low titer positivity. What is
that you have to question the laboratory. Yeah. What you can see is one MSA and 1 or 2 MAA. That can occur. But multiple MSA has not been reported in the literature till now, to the best of my knowledge. Whatever I read, maybe Mishra can add to that. I may have missed some paper, some rare present. I don't know really, but to the best of my knowledge, not so.
Another thing is that if we get MSA positivity in normal population, do you like a few of the series, they have reported MSA positivity in 1 to 2% of general population.
That is a research question. I will not be able to answer. Somebody who is involved very deeply, I'm sure my colleagues who are doing these studies in the population may answer. Maybe Mishra knows about that, because I'm sure there is a whole group of myositis youngsters who are involved. Maybe they can answer that if they are joined in on this webinar.
Dr. Mishra, any comment?
Yeah, I just want to make a comment. These antibody interpretation depend on the methods of detection. If you are doing something like a line blot, which is sensitive, you can get a situation that some normal individual may have it, may have a slightly gray band and 1+ or 2+. It means nothing. And it has to be corroborated with either the ELISA test, and gold standard is immunoprecipitation. Yeah. None of the labs in India, only one lab in entire USA, that is Ira Targoff lab in Oklahoma, and one lab in entire Europe has doing the assay for immunoprecipitation, either the Peter Charles at the Charing Cross, then or Neil doing at the where is that? And they are trying in some France center. it's a very labor-intensive test. So, but that is the gold standard. All of these various autoantibodies that have been detected. The initial survey of the samples from patients, they had very few co-occurrence of myositis-specific autoantibodies together. With the availability of this line blot assay by Euroimmune, we tend to see co-occurrence.
Oh, really? That I didn't know.
Yeah.
Because these are very sensitive.
Maybe a little bit somewhere here.
And meaningless at times.
Yeah, meaningless.
Meaningless.
So
and
practically
for
still
meaningless test, you need an ELISA test for confirmation. That will be again expensive. Some of the private firms, they charge 12 to 15,000 to do the test. It's terribly expensive.
I must say, I won't name them, but one of the commercial laboratory in Delhi, they are in close touch with us and they are doing it in fairly less money and they are doing good job. I have seen their reports.
Okay.
I'm happy. And they have been calling me repeatedly to give talks on their platform.
So
and
there are two panels. There are two panels. One is the limited panel and one is the extended
Yes,
panel.
the extended panel is really doing a good job, I must say.
So that's
Expensive.
Basically,
15,000, yeah.
So it's not only for myositis, it's for scleroderma, it's for SLE, it's in general.
Overlap and all.
If you use a sensitive test, we have autoimmune markers in us, all of us. It's just that, but there aren't been studies to see the predictive significance of this marker in the setting of myositis. We have studies for antibody to CCP. If you have positivity, in times you develop the disease. But if you have anti-Jo1, there aren't any predictive study to suggest that you will develop a disease, and therefore it doesn't warrant treatment, it warrants assurance.
Absolutely, sir. Basically, there are 2-3 reports published in Rheumatology 2020, and there is one study from US that says that false positivity of line blot, Euroline myositis antigen profile 4, is around 15%, and dot blot it is around 13%. Similarly, in another study, they have mentioned that false negativity for anti-TIF1 is around 25%. That is from USA and France.
Yeah, I know there are some labs which have access to immunoprecipitation. They don't believe in this.
Yeah,
These line blot, they believe in doing a recombinant based ELISA assay and confirmation by immunoblot, immunoprecipitation.
So next question is to Dr. Mishra, sir. How to measure response of treatment within 1 month after high dose of corticosteroid to decide for rituximab or IVIG in necrotizing myopathy? Response in terms,
assessment of response is based on clinical grounds. Lowering CPK 50% lower, 90% lower has got no meaning. It is the clinical response. If there is ventilation is less required, muscle power has improved, that has to be catered into. Sometimes you see regenerating muscle also, enzymes come out. CPK is at the end of 1 month is not a good marker for response. If you have it, then it's good. But our gold standard of improvement is improvement of functional outcome and our objective MMT testing.
Okay. Next question to Dr. Malaviya, sir. Can ANA be positive in anti-synthetase syndrome? Second, if patient is having anti-Jo1 positive with elevated CPK, ILD with fibrotic NSIP without other antibodies, can we consider that case as anti-synthetase syndrome? Dr. Dimple.
The question is whether ANA is positive.
Yeah, can ANA be positive in anti-synthetase syndrome? Yes.
Mishra will have to answer that. I really don't know. The second question. Yes.
Can I?
Yes.
Sir, all these myositis specific autoantibodies, they are mainly have a cytoplasmic.
Cytoplasmic
So
antibody.
they are anti-nuclear antibody positive because of myositis associated antibodies. So if they are co-occurrence of RNP or Rho, then you can have a ANP. Some Jo1 pattern of nuclear has been described, but primarily they work in cytoplasmic domain. The biological is cytoplasmic. So to have a anti-ANA positive means you have a myositis associated antibodies. That is my understanding.
Exactly, and I will just extend what Mishra is saying. When we say anti-nuclear, if historically you are really talking about the antigens that are present in the nucleus. But now what happened, and in those days, when we started doing ANA for the first time in India as well as abroad in 60s, we didn't pay attention to the fluorescence that was visible occasionally in the cytoplasm. And we will call all of them as anti-nuclear. But when we started becoming aware that there are patients who are now showing shiny spots in the cytoplasm, people got interested and then they went into detail of what those antigens are. And therefore, we found that there are many antigens that are present in the cytoplasm, and in autoimmune diseases of the category that we are dealing with, the antibodies are reacting with not those antigens that are present in the nucleus, but in the cytoplasm. But because of nomenclature, what should I call them? It became clear that if I give them the name anti-cells antibodies, then all the previous reports and publications in the libraries, if somebody goes and tries to take out all those papers which have reported from the year 1960 onwards, all those old papers will be missed. And therefore, indexing became a problem. And the reason for that, because of that, anti-nuclear is still being called anti-nuclear, although as just Mishra has explained, now it has started including anti-cytoplasmic antibodies also within the category. And thus we have now ICAP 29, ICAP International, which gives 29 different patterns that not only includes cytoplasm, but includes the mitotic body, it includes different parts of nucleus, nuclear membrane, and everything. So yes, they answered in short the question asked by our colleague. Yes, yeah, you can find anti-nuclear antibody in many of these who have anti-MSA antibodies. The second part was what?
If patient is having anti-Jo1 positive with elevated CK, ILD with NSIP pattern, without other antibodies, can we consider that case as anti-synthetase syndrome? I think yes.
Yes, that's a typical anti-Jo1 antibody. Mishra can even add to that. Jo1 is present.
There are one slide of mine had incomplete variant of.
Okay, yeah.
So this could fit in it, and depending upon the organ manifestation or the organ severity, one can treat.
Sir, Dr. Mishra, sir, some of the early inflammatory arthritis patients, they have Raynaud's phenomena and low titer ANA positivity without any other extra articular features. Do we really look for the this anti-synthetase syndrome in this group of the patient, because they can also develop?
Yeah, yes and no, because if the ANA titer is more than 1080, then you do it. If the ANA titer is 1 in 80, 1 in 160, don't bother, because some of the rheumatoid arthritis patients themselves have ANA positive at that. But if the ANA titer is 1000, 3200, you go ahead and do it.
Excellent.
Can I just add to this what Mishra has said? I will just like to elaborate. Who has asked this question?
Sir, myself.
Oh, you. Okay. Banwari, what is happening is you are aware of it. with increase in sensitivity of the testing for anti-nuclear, and you have read Lipsky's and Pisetsky's articles. Anti-nuclear antibody test that was so sacrosanct and all with lupus has now become a waste paper basket. Totally waste paper basket in the sense that if you take randomly 100 normal people, 40 of them give anti-nuclear antibody positivity. And Kapoor and myself and Garg, we have been discussing that they have really spoiled the whole thing related to ANA. Every one that we get, any type of, and this is being done now widely by those who are not rheumatologists. It is called rheumatology panel, arthritis panel. And anti-nuclear is done in fibromyalgia, in all kind of non-specific pains, osteoarthritis and all that. And all of them are coming with 1 in 80, 1 in 40 titer positive. And they are being referred to as ANA positive. Is it lupus? The answer is very simple, that Raynaud's phenomena is present at least in the northern India in 20 to 30% of women, and you can talk to them during peak winter in Delhi or Jaipur. During December and January, they have a little bit of blueness in their fingers, and this is primary Raynaud's, which occurs entirely in women. Of course, a male with Raynaud's has to be scleroderma or one of these diseases. So there it's a very different thing. And therefore, I will say, if the ANA is in the range that you keep seeing every day, up to 100, I don't bother. I say, throw it in the waste paper basket.
Okay. The next question to Dr. Malaviya, sir. 2 questions from Dr. Vijay K.R. Rao from Bangalore. Role of JAK inhibitors in dermatomyositis and polymyositis. Second question is drug-free remission possible in inflammatory myositis over the time?
Second one is an easy one because I have 55 years of experience with dermatopolymyositis. 55. And I can go around and scratch my head and tell you at least 20 I can give names where treatment has been stopped completely. But I must say, in retrospect, almost all of them were what we knew as dermatomyositis, which was MI2 in today's language. So if you have MI2, I still have many patients who are still visiting my clinic where I've stopped glucocorticoids long ago, and they are on minimal doses of methotrexate, which is my very favorite drug. And I also add hydroxychloroquine in most of them. So the answer to that is yes, drug-free interval is available in a certain subset of dermatopolymyositis. And our younger group who is studying the dermatopolymyositis in India will come up with this, I'm sure, in a more scientific way. The second question was what?
The role of JAK inhibitors. JAK inhibitors.
JAK inhibitor, the control trials are still not available. But there are several reports that JAK inhibitors could be a drug for improvement of certain subsets. One of the subsets which is mentioned is MDA5. There is a case report actually in Oxford Rheumatology that tofacitinib was of some help in a patient who had MDA5 type of dermatomyositis.
Yeah, and there was basically 23 patients retrospective analysis from China that showed that tofacitinib improves survival of all anti-MDA5 patients. They gave tofacitinib for 6 months. Yeah,
I think that's the one I was referring. It was not a case report. You are right. There were some observational studies. Observational,
yes, sir. So next question to Professor Mishra. I am an elderly patient with TIF1 gamma positive myositis, ILD, arthritis, and skin thickening with non-pathognomic skin features of dermatomyositis and with fever. Is this overlap myositis?
I think sir will answer that. Sir covered TIF1 gamma.
Yeah.
So maybe
I repeat.
Yes, I found. I mean, there is an interstitial lung disease which tells that TIF Gamma is not usually interstitial lung disease, so there has to be some overlap. What is the report on MAA? That will be my question in this case. Any feature, any antibodies that are seen in other connective tissue diseases?
No, basically here she has mentioned TIF1 gamma is positive.
That's the only one.
Skin thickening and skin rashes, but not pathognomic of dermatomyositis, and fever also.
This looks to me more like there is some overlap with primary, with systemic sclerosis.
And her PET CT is normal.
Systemic sclerosis comes to my mind with thickened skin and interstitial lung disease. That's what I will be wondering about the overlap, because these two in TIF gamma, interstitial lung disease is not known, while in systemic sclerosis, ILD will be explained and thickening of the skin will go along with it. Is there a history of Raynaud's or not?
Not
because
mentioned.
that will again go in favor of systemic sclerosis. That's what I can say, but I can't. I mean, maybe Mishra can add to this.
To me, the clinical picture looks more like systemic sclerosis.
Overlap with this.
With overlap with serological overlap.
Overlap.
With
Yeah.
alpha.
Yeah.
I don't think we need to worry for underlying malignancy in this situation.
Yeah.
Absolutely, because there are reports that says that if anti-TIF antibody is positive in other CTDs other than this dermatomyositis, malignancy risk is not high.
Yeah, then the significance of TIF gamma goes down.
Yeah, absolutely. And role of tofacitinib in MDF5 type we have discussed. The next question is, I have one patient with polyarthritis resembling RA, seronegative, ANA positive, and ENA shows Me2 positivity, but no skin lesions, only arthritis.
Again, Mishra's just said that there are problems. A little bit gray line in MI2 and ANA. I think I will, if clinically there is nothing, I will not worry about it and consider it as a false positive.
If one thing I want to say, as people were listening, all these, why would one do a Me2 antibody in the
precisely?
Why?
That's great. That's great.
It is if is one dealing with a seronegative rheumatoid arthritis and there are no extra-articular manifestations of lupus, you don't worry. You stop at that. If it is antibody to CCP, then it's a good outcome. To do a Me2 or a myositis specific antibody is like bel mere ko maar.
Thank you, Mishra. This is a great answer, and I will strongly recommend my colleagues to refrain from getting unnecessary tests done if clinically they are not indicated.
Next question is again simple. So, do you start a steroid sparing immunosuppression upfront in patient with raised OTPT due to myositis, or should one wait for normalization of these with the use of a steroid first? Dr. Sakshi Mittal.
I didn't get the question.
Basically, the question is, because of myositis, there is increase in SGOT and SGPT. So should we start only steroid, or should we start a steroid with immunosuppression upfront? Should we wait for the normalization of OTPT?
Oh, yeah. I guess we will have to, I mean, if other myositis related enzymes, CPK and others are also elevated, and we are by electromyography, it is a typical case of myositis, then I guess we will have to wait till liver enzymes come down, because I don't know whether the patient has fatty liver and that may be adding to the liver enzymes. So just be careful and give only steroid. I guess that is a practical way of looking at it. I can't be an expert in this. Maybe Mishra can help.
But I think, sir, we see elevation of OTPT because of myositis per se. So,
yes, I know. But in India, this fatty liver issue is becoming so widespread that any liver enzyme elevation, I get a bit concerned, and I would like the liver people to do the fibroscan and let me know whether the liver is really okay.
Dr. Mishra, sir?
Yeah, I agree with that elevation of these enzymes, which liver enzymes, which could have been coming from the muscle source, is quite possible. Now, the real question was upfront to give an immunosuppressant drug with steroid. There is a difference of opinion. Usually, I teach to start steroid and wait for 4 weeks to add a second drug. But my colleagues who are, I would label them more aggressive, they start upfront and they have a logic which I can't deny. They say you add aducanum methotrexate, you can reduce the steroid early by 3-4 weeks. If you add azathioprine, then you can cut down the steroid. See, there is no randomized control for inflammatory myositis. It is whoever is shouting louder can convince that, no, if I do it this way, you. But I am more conventionally trained. I give that, and I accept the fact that there could be a logic of starting a second drug could minimize the side effect of steroid because you have to treat them for a long time.
Mishra, you are in a very good company of a large number of rheumatologists.
Yes.
Majority will say these drugs, the second line drugs, they call them, and not to give them in the beginning because this disease can be treated almost entirely with glucocorticoids. I often give methotrexate together. I must say there are no controlled trials. And if we go to controlled trials, this is very not widely known. Till today, there is no controlled trial on the use of methotrexate in dermatomyositis.
Yeah,
it is entirely based on experience throughout the world. And that's why many of the guidelines put methotrexate after azathioprine and not as first drug. But because of emotional involvement of mine with methotrexate, I give it, not for scientific reasons.
So last
in all conditions where steroid comes into picture as a therapeutic intervention modality or other drugs are anchoring on them, it is very difficult to do randomized control. No ethics committee would ever permit an arm which is not steroid. Maybe in the lupus trial, avocapan, or in the systemic vasculitis, what one can think of, but inducing a remission without steroid, I don't think it is possible now.
So the last question is, can IgA vasculitis be seen in dermatomyositis? This is the first thing. Second thing is, and what is the significance of TIF1 gamma 1 plus positivity along with PL12, 1 plus positivity? Like both are 1 plus 1 plus positive, TIF1 gamma and PL12.
Mishra can answer this.
Ignore.
Ignore.
Ignore the TIF1 gamma with positivity of PL12. You best ignore it. Don't take it further. Yeah, you go by your clinical sense of the patient. What does the patient complain? If she has arthritis, you treat the arthritis. If she has ILD, you look at that. This TIF1 gamma or the presence of PL12 don't consider or give weightage to it in your clinical, in the treatment of the patient. And that's a mild positive.
Fully agree, yeah.
So before concluding the today's session, I request Professor Malaviya sir and Professor Mishra sir to give one final comment, one final message to audience about this interesting topic. One.
My message is very simple. In the majority, you will see the classical case of dermatomyositis, where I don't have to worry much. Very good clinical history and a physical examination is enough to tell you that this is the garden variety of disease and the majority will be a mild type of disease. You start with glucocorticoids. Mishra will probably not give anything else. If I am there, I have this, that methotrexate will help me reduce the steroid dose very quickly, and just follow them up, and majority will do quite well. This is my answer. But if you take the history and there is Raynaud's phenomena, or there is some breathing problem, or the muscle severity is quite a bit, or there is swallowing difficulty, or if there's some peculiar lesions on the fingers which resemble mechanic's hand, or all those things that we mentioned, in such a case, you have to be very careful. And then whatever we talked, you go through those investigations so that you are not missing a patient who will rapidly deteriorate. Thank you.
Dr. Mishra, sir.
I have got some bullet points to share. First, myositis, group of disease, inflammatory are rare disease. So other autoimmune diseases are common. Second, if there are clinical features that fit along with enzyme abnormality, EMG, treat. You treat and don't taper the steroid fast. Whatever patients I have seen treated by usually non-rheumatologists, they usually taper the steroid very fast within 4 weeks, and then there is a relapse. Once we have a relapse, there is problem with this group of disease. Don't over-interpret the autoimmune myositis specific autoantibodies. Don't over. If it fits in with your clinical criteria, then it's fine. If it's a pure muscle weakness disease, you get MGA, HMG co-reductase, SRP, then it's a dreadful situation, you act. But if the me2 clinical phenotype is not there and me2 is positive, don't worry about it.
Thank you, sir. So thank you, Dr. Malaviya, sir. Thank you, Dr. Mishra, sir.
Thank you
for sparing time on Sunday and giving this excellent lecture for the audience. And I thank all the audience for attending this wonderful talk on Sunday afternoon. Thank you, everyone.
Thank you, everyone. Thank you, Ramnath. Thank you, Balwari. Bye-bye.